So how to tackle post-operative refractive surprises in our day-to-day practice. So we are not, we will be very happy if our patients fly to USA for a treatment after refractive surprise, but this doesn't happen with all of us because we have to handle our own patients. And the monofocal, the EDOFs, the multifocal, so many things we are telling to the patient that you will be the glass free. And after monofocal implantation also, so many patients are telling that I cannot see for near. So these kind of things are happening nowadays. So patients are demanding more. We are also telling patients that you will be glass free and like this. So for all these surprises, how to tackle, because our patients we have to tackle our own by our ways. So what are the problems and from where the problem starts is a pre-operative, some patients with a biometry errors, sometimes inappropriate IOL formulas if we use pre-operative astigmatism, which we have not seen for the pre-operative astigmatism. Some in operative cases like a surgical induced SIA, we cannot say how much will be induced. Sometimes it gets more induced. Misalignment of the IOLs, surgical complications, inverted upside down IOLs, anything can happen at the time of surgery. So all these pre-operative, operative and post-operative. In a post-operative complications like anterior lens capsular phimosis, lens tilt, PCO, these all are the problems where the patient will have some kind of refractive surprises. So in our day-to-day practice, 80% of the patients we are giving a good chair time, counseling the patients and convincing them for the glasses. So 80% patients we are sending them back with some kind of satisfaction. But in a 20% of cases, they will not accept any of your things. They want some correction has to be happened. In these cases, what to do? So there are some cornea-based surgeries like LASIK, PRK, LRIs you can do. Some lens-based procedures like sir has shown the IOL exchange, madam has shown the piggy bag IOLs, IOL redialings are there. So I will just show my three cases the same way we have handled, but sometimes something wrongly happened. This is a 50 years male patient having a mature cataract. Implanted, our counselor has counseled them for a multifocal IOL. I was not knowing, and they told that you will be glass free, and surprisingly, the post-operative refraction was -6. And I have done the very nice Rexis of 5 millimeter and implanted the plate haptic design multifocal IOL. So it was very difficult for me to explant the IOL. In that case, I have done the Sulcoflex IOL. Nomograms for Sulcoflex IOLs, like madam has told, the Rayner has its, they have patented this Sulcoflex IOL, and they were using, they have a monopoly of the lenses, but now the good Indian company like IOCare has came in the market with the Sulcoflex IOL. Also you can think of a phakic lens also you can put in the like a piggy bag IOL. So this was you can see that multifocal IOL has been implanted with good rings are there, but post-operative refraction was -6. I have done under only topical. I have taken so much time that what went wrong for this case, but I found that only this is the solution in front of me, that I should go ahead with the piggy bag IOL, because I was not sure that if I am trying to explant the lens, definitely the whole bag will come with the lens. So I have just implanted the lens inside the sulcus, and patient is happy, I am also happy. So second case was 55 years old male implanted with a monofocal IOL, and surprisingly the post-operative refraction was -3. Patient was sometimes they also very keen that no, why -3? No, it's good for you, that other I will do you for 6x6. This I will work for near, this I counseled lot of times, this is very good for you, for one I will work for near and other I will work for distance. But the patient was not understanding. So I have gone back, went wrong, definitely the IOL power was wrongly chosen, so I have taken a decision that I should exchange the IOL. So I have done the IOL exchange under topical anesthesia, but I use scaffold IOL technique. So many times what happens, we are always worried about the PC. So if you just lift the lens from the bag and put one more lens inside the bag. So the PC will be tightened and it will be away from the, see, I have just lifted the one lens and now I am putting the monofocal IOL in the bag itself. If it goes down, you are away from the PC, and PC means you will never touch the PC. And then you lift the first IOL, cut it and remove it. Very simple. So there are two lenses you can see. That one is now going inside the bag, and second I am just lifting and cutting. So this is the second IOL. So second also no need to cut whole or 3-4 pieces. You just cut it triangular shape, slightly increase the incision from 2.2 to my incision is 2.2. I have just increased to 3 millimeter, might be, and just cut it like triangular. You remove that piece of that triangular cut IOL, and whole lens you can remove. Now you have to just remove the first, and then from the incision you just rotate this lens like this. So definitely it will come out. So just move like this. And third case is a 50 years female. I have implanted with J&J Ihans lens. I have committed her that she will get a very intermediate good vision, and taken a good money also. But the patient had a refraction of -1.75. I have counseled her for exchange of IOL. She told me, no, I don't want any surgery right now. I want this vision back, and otherwise you give my money back. I told, no, you come, I will not go inside your eye, I will do the laser. So I did LASIK in her, and she was glass free, 1.75, very, means only after 24 days of post cataract, I did her LASIK very excellently. Now she is also happy. 1.75, you can precisely give the refraction and refractive error you can correct in these patients. So LASIK is also a good option post cataract, or you can do a PRK also. So many are not convinced that you are giving the suction on a 21 day or 1 month post operative, but really saying nothing will happen, no wounds get opened. This is actual case after 21st day, because you cannot, some paper says that 3 months you have to wait for the lens and incision has to settle. But 3 months, a cataract patient sitting on your head, I don't feel that's a good idea. So better I have taken the risk, I have opened, I have done the LASIK, and patient is happy. So, and some cases like cornea-based redialing of the IOL, sir has already shown. So thank you very much for your patience talking. Thank you.
Thank you, Dr. Deshpande. That was